Welcome to our Preparing DIS to Connect MSM Clients to PrEP, a product of the National Coalition of STD Directors MSM Community and DIS Community Practice. My name is Desiree Smith, and I'm the Health Equity Manager at NCSD. I'm also joined by my colleague, Leandra Lacey, who's the Senior Manager of Capacity Building and Member Engagement. Within the ever-evolving landscape of STD and HIV prevention field, DIS are often taking on additional duties such as referring clients to PrEP services, with men who have sex with men being a priority population in STD HIV prevention. It is imperative that DIS are engaging with MSM clients effectively and linking them to PrEP when appropriate. Today we'll be discussing how some jurisdictions are doing this work.
Thanks, Desiree. So all participants have been muted right now. If you have questions or need technical help during the webinar, you can use the chat function in the bottom right-hand corner of your screen. You can also private message me, Leandra Lacey, Desiree, or our colleague Tiffany Haskell. We're all listed as hosts in the top right-hand corner of your screen. All questions for presenters will be addressed at the end, but we will keep a queue, so please send them our way as they come up. This webinar is being recorded. The recording and the presentation slides will be emailed to those that register, and these materials will also be placed on the NCSD website.
So the objective of this webinar is to highlight our program speaking about their process regarding DIS and referring MSM clients to PrEP at local clinics or other local agencies, DIS describing PrEP in the in-house setting at the health department, and then also training the DIS to speak about PrEP and motivating MSM clients to start PrEP if they're an appropriate candidate.
So first up, we'll have presenters from the DC Health and Wellness Center. We'll have Tony Fleming, who's the Field Operations Manager, and Herman Jones, who's a Disease Intervention Specialist there. Other DIS that may add their experiences or comments during the presentation are Tony White and Malachi Stewart. So take it away, y'all.
Good afternoon, everyone. Can everyone hear me? Okay. So my name is Tony Fleming. I'm the Field Operations Manager for DC Department of Health. And presenting with me is Herman Jones, who is also a DIS with DC Health Department. And today we're going to be talking about DIS PrEP follow-up in the district. So just a little bit of background for DC government, what is going on?
Tony, can you speak up just a little bit into your phone?
Yes, sorry.
Perfect, thank you.
Okay, so just a little bit of background. According to our 2018 annual report, we have about 12,322 cases of HIV living in HIV for DC population. And from that, we have about 1.8% of our population that is living with HIV. And from that, we have 3.2% who are aged 50 and older. And this is based on the end of 2018 in our annual report. And our proportion of our HIV cases living in DC by race and ethnicity and gender identity and mode of transmission here in DC based on our 2018 data. Our Black MSM and MSM IDU, 27%, which is our highest proportion, followed by our Black heterosexual women, and then our white MSM and MSM IDU at 13%. An overview of our organization, our HIV/AIDS, hepatitis, STD, TB administration, also known as HOSTA, is where our STD and TB control division falls under. Our STD TB control division also houses our disease intervention and investigation branch, which is formerly known as Field Operations, as well as our DC Health and Wellness Center. We're going to focus on our disease intervention and investigation branch, where our disease intervention specialists are housed. With this program, we have one field operations manager, which is myself, two lead investigators. One is actually a CDC assignee, which we formerly were called our first line supervisors, but now that's renamed to our lead investigators. And then we have 8 total DIS here. One is actually permanently housed at our DC Health and Wellness Center, and we have 7 that are actually in our, that stays in the field. So there's no clinic kind of rotation. Currently, that's our new process that we've made changes to. And then we have 1 CDC consultant. For DIS PrEP for MSM, as you see that we had 27% of our population was of Black MSM IDU. We do have a focus or priority for MSM and PrEP, but we also have other priorities as well. Just kind of going back initially, how DIS are assigned work or field investigations is through our surveillance system. So once that investigation is completed, then that information is then assigned to our staff for follow-up. This includes positive syphilis tests, which are early latent syphilis, primary and secondary, as well as new diagnoses and any co-infection cases with gonorrhea and chlamydia. We also will follow up with positive STIs with negative or unknown HIV status. So that this also means that we will ensure that all of our positive cases that we are known to identify as we are unknown for HIV status, we will try to refer them in for testing and initially before our PrEP initiation. Also, we'll also encourage our partners, suspects, and associates that we identify and refer them in for testing and treatment before our PrEP initiation. Our initial documentation is in our information system. So back in, I would say about 2015, 2016, our documentation for DIS to verify PrEP information was mainly through our notes. So we would document that. Now we have a couple of structured fields to identify and measure the amount of clients who are enrolled in PrEP or already in PrEP. And going forward, when we do have our upgrade in our information system, we'll be adding additional information regarding where the patient was tested, their last PrEP appointment, etc. So I'm going to pass it on to Herman to talk about our field investigations.
Good afternoon. My name is Herman Jones. I'm a DIS here in D.C. And now we're going to talk about the field initiation. Once the DIS is established where the patient would like to get PrEP, what we normally try to do is schedule an appointment for the person. This is on clinic. But a lot of times we do most of our interviews are done by phone because of the transient population we have in D.C. and most people are working. So what we'll do is we'll talk with a person during our partner services interview. We'll maintain information gather information from them on what they know about PrEP. Are they currently on PrEP? If they are on PrEP, we try to find out who the provider's name is. We try to get other information from them to make sure how long they've been taking PrEP. And then we'll try to go through either the provider or our lead DIS can check with the labs to see if we have any lab work to kind of line up with a person being on PrEP. That allows us to be able to get things taken care of as quickly as we possibly can. I got my paperwork mixed up. Indeed. Wait a minute. I'm missing a sheet here, Tony. Once a person comes on clinic, what we'll do at that point, we'll discuss PrEP with the person or during the risk reduction section of the interview. And then if the person stays already in PrEP, we already went through that. So we'll go to the next slide. In DC, we have over 40. Why is that? Okay, we're through this. We verified. And all right, once we've established where the person is on PrEP, We try to contact the PrEP provider and schedule an appointment for that person to go in for if they want us to. We also provide a referral to a patient if they refuse to schedule an appointment at the same time of the interview. With DIS, we'll attempt to confirm that the person has attended their PrEP appointments. Some of the obstacles we're facing right now is that a lot of verification from providers is kind of hard in DC. Some providers report very easily, and some providers we have good relationships with, but sometimes people do not want to disclose to us who they receive a PrEP from. And I'll turn it back over to Tony.
Okay, our next process in our DIS PrEP initiation is at the DC Health and Wellness Center. As I stated before, we currently have one DIS assigned at the DC Health and Wellness Center, and their role there is to counsel positive patients diagnosed with syphilis, HIV, chlamydia, and gonorrhea, provide partner services for positive patients who are diagnosed with syphilis, HIV, and or gonorrhea and chlamydia co-infections. Those patients who have negative rapid tests will also have a discussion with our DIS, and then we'll offer PrEP. And if the patient agrees, then we will do a warm handoff to what we have as a PrEP coordinator, PrEP navigator at our DC Health and Wellness Center. So they are kind of located next to each other. So when that patient does agree, then we can kind of do that warm handoff to our navigator. And then if patients who are not seen by our DIS are interested in PrEP, meaning that they may have not had any positive tests but are interested, then that interaction comes from the clinician, and then the clinician will then do that warm handoff to our PrEP coordinator. Continued on, our PrEP navigator then does completes a risk assessment, address any insurance or other alternatives, or if the patient doesn't have insurance, they'll set up also set up follow-up appointments and do any kind of pending follow-up. This also includes providing coverage for PrEP. So, for example, our clients may have private insurance, Medicaid, Amerigroup, and then for the uninsured, we also have a Gilead patient assistance program as well as Patient Assistance Network, and then we have a new program which is our DC PrEP-Jan. And depending on the patient's financial background and insurance status, PrEP and PEP is available at low or no cost.
Okay, and now to give you a little idea of the clinic flow, when a person comes into the clinic, we first gather their sexual history, their medical history. We try to find out the HIV status, find out any kidney infection diseases, hepatitis status. We'll do a rapid HIV test on them. We'll also do complete metabolic panel, 4th generation tests, hepatitis A and B, hepatitis C reflex, and GC, chlamydia, and syphilis testing. After they meet with the PrEP coordinator and they've discussed the situation with the PrEP coordinator and they've decided that they are eligible for the program, we will give them a 7-day supply in their hand before they leave. We used to do it 30 days, but we found it's more easier to give them 7 days so we can know we can get them back. And on this 1 week visit, we'll check to see if they had any side effect problems, any adherence problems, if they missed any medication during the last week. We'll assess any needs that they have because we have the labs back from the laboratory, anything that they need like hepatitis A and B vaccine, or if you need hepatitis C follow-up. Also, and at the end of that meeting, if everything is okay, we'll give them a 30-day referral, 2 months. And they'll return in 3 months. We'll check to see if they had any side effects, any adherent problems. We'll check the vaccine status, make sure that they made all their appointments, do other testing to make sure that they have haven't contracted syphilis, chlamydia, gonorrhea during that period of time, and we'll give them another 30-day prescription with 2 refills at that time. The things we've learned here at the clinic is that the PrEP program here at DC is effective in its inception. there have been some changes that we have made that have been required for the patients. Initially, we would give them 30 days of medication, but now we only give them 7 days. This brings the patient back for a 1-week follow-up instead of a 1-month follow-up. It's easier for a person. It's about 95% more convenient for them to return in the first 7 days than the first 30 days. We offer on-site PrEP navigation is key to optimizing the patient's access and adherence to PrEP. Ongoing discussions regarding the possibility of adding a case manager for the PrEP team to coordinate access to additional services, because we have a lot of people come in that are homeless, have mental health issues, you need drug treatment, and et cetera. We try to see if we can figure out a way to get those things taken care of for them also.
Okay. What are we doing to enhance the PrEP program in the district? We now hired a PrEP coordinator in the district. This PrEP coordinator does have a background of a DI background, self-starting, solution-oriented, maintaining strong, productive working relationships, problem-solving, coordinating activities, presentation skills. So that's what we look for when we hired this new PrEP coordinator. So overall, this PrEP coordinator now falls under the Care and Treatment Division, and this PrEP coordinator now provides and promotes PrEP education, address programmatic workflows, challenges regarding PrEP and PEP, helps capacity building and developing or revising policies and procedures, quality assurance trainings and resources, implementation of best practices that comply with adopted policies, laws, and regulations, and also works with hospital staff regarding our PrEP and data collection. So I think that is the better kind of overview of what our new steps are, where we are reaching out to the community who really don't have, who want to start PrEP programs, and having this PrEP coordinator is also a benefit to help with capacity building and starting these PrEP programs in the district. Now that's pretty much it.
She was in the middle.
Thanks, CC.
Thank you. So next up, we have two presenters from Champaign-Urbana Public Health District in Illinois, Candy Kraus, the Director of Teen and Adult Services, and Nancy Johnson, the PrEP Program Lead.
Hello, folks. My name is Candy Kraus, and I'm going to talk to you a little bit about the background of our PrEP clinic in Champaign. I thank you all for participating with us today and allowing us to share our program. I'm excited to see where this goes and how PrEP services expand following this session. Champaign-Urbana is about 2 hours south of Chicago. We are a small community, or a medium-sized community in a small rural area. As you can see, Champaign, the cities of Champaign and Urbana consist of about 130,000 people, whereas the county is only 210,000. We have the University of Illinois at Champaign-Urbana, and so that draws a lot of folks to our community. It's described as micro-urban, which means that we have a pretty diverse and cultural community without all the traffic of a larger city. This is a map of the distribution of HIV in Illinois. As you can see from the map, Champaign's there in the middle of the state. Our highest prevalence counties are around Chicago, and they're around St. Louis, which is in the lower or in the southwest area of the state. Champaign's right in the middle, and we're a moderate prevalence county. We are able to, we do get some grant monies for our HIV services, and we have prioritized our HIV services in our health department for the last 20 years. Back in about 2014, we started to get calls from our clients asking about PrEP, and we had heard of the intervention, but we didn't imagine at that time that we would be involved in actually prescribing Truvada for PrEP. We figured we would be referring to our local physicians and setting up the networks that like what our partners in DC had just described. We talked to our hospital and clinic partners, and they set policy that they would refer all persons requesting the PrEP intervention to their infectious disease doctors, which we were hearing from our clients wasn't a good fit for them. So our university health center was also not interested in PrEP interventions at that time. So we early in 2015 we started to look at what it would take to set up a PrEP clinic in our health department. Our health department has about 125 staff, and the Division of Teen and Adult Services, where our PrEP clinic is housed, we have about 20 staff, and you can see that it's a mix of a nurse practitioner, nurses, our STI and HIV services staff, 3 support staff, and program coordinators to ensure that we keep services moving. The HIV services, STI HIV services staff are a mixed group as well. They're cross-trained to provide education, testing, and supportive services for STIs and HIV. They conduct both HIV prevention and Ryan White care services to meet the clients where they are. And then DIS activities are interwoven into all of these services. We have teams of DIS. We have a STI DIS team, an HIV DIS team, and a TB DIS team at CUPHC. So again, this is a diverse staff that's able to address the various needs of clients as they encounter them in the field or in the office. I'm going to introduce Nancy, who's going to talk more about our integrated clinic.
Hello, my name is Nancy Johnson. I use she pronouns. I'm going to go over a little more detail on how our PrEP clinic runs, as well as how DIS plays a really important part in our PrEP clinic. So we are an integrated health clinic. We are open Monday through Friday from 8 to 5. We do have some other side stuff that we do on weekends and holidays, or weekends and evenings, I'm sorry. But for the most part, we like to see our clinic as kind of a one-stop shop. So a lot of our clients that come through for STD services or Ryan White services or whatever services we may be providing that particular person, a lot of times that's the only medical care that they're receiving. So we try to look at it as being able to get them help with as many different areas as possible while we have the chance. So with that being said, our PrEP clinic, the typical flow of our PrEP clinic is very similar to DC Health and Wellnesses. So I'm not going to go over each of those points for you again, but we run very similar PrEP clinics. I will just point out under where it says nursing assessment, so a lot of what the nurses do for us, a lot of our clients come in through the STD clinic and see, a nurse to begin with, and that nurse will kind of assess that client for the different services that they may benefit from, and a lot of that will have to do with assessing for vaccines, offering whatever's available to them, and then doing the site-specific STI testing, and always talking about PrEP. So we talk to every single person that comes through our clinic about PrEP. The STI HIV services staff, when they're meeting with them, their role initially is more to just answer questions that they might have about, how PrEP works and how the appointment that day is going to work and how the follow-up appointments are going to work, explaining things like why they need to be tested for hepatitis B and why we're drawing blood for their kidney function tests and things like that. When the person decides then that they want to go ahead and move forward with going through a PrEP appointment and being prescribed PrEP, we assign each of our PrEP clients a care coordinator or case manager, and that person is kind of their go-to person for the whole time they're on PrEP. So we had, decided that it would be good for them to be able to build a relationship and be able to have a specific person to talk to at the clinic when they had questions. So those care coordinators go through things like Medicaid enrollment for them, the prescription assistance, copay cards, making sure that they are able to pick up their prescription, so they will generally call 24 to 48 hours after the person has left our clinic to make sure that they've been able to pick up their prescription. And where DIS plays an important part in this is that they have contact with individuals repeatedly. So we see a lot of repeat infections come through. So our DIS staff, are meeting with people maybe 2 or 3 times a year to discuss things like partner services and things like that. And it's a good opportunity for them then to roll that conversation into highlighting how, in repeated STDs and STI infections can increase your risk of HIV. And our DIS staff tends to have a better relationship with those individuals that they're trying to, roll into care for us. When we talk about PrEP engagement benefits for DIS staff, we try to connect the clients to a system of services, and that kind of goes back to how we try to do everything in a one-stop shop. So we may be referring our clients that come through, either DIS clients or people that are just visiting the clinic, for things like family planning, housing opportunities, insurance enrollment, and things like that. So since we began our PrEP clinic in June of 2015, and then through December of 2019, which is when I got these numbers, we've had 274 persons who have come through our clinic and received prescriptions. Currently, we have 86 active clients. 77 of them identified as men who sleep with other men, 5 were women, and then the remaining 4 were clients that identified as heterosexual men who had partners that were living with HIV. And lastly, for my part at least, and then I'll move it back over to Candy, the lessons that we learned are, Truvada and Descovy, which is what everyone thinks of when they think of PrEP, but PrEP is actually a lot more than just the medications. So it's the ongoing medical appointments, the STI testing, the opportunity to get vaccines that people may not have gotten, and then the PrEP care coordination actually goes far and beyond the PrEP visits as well.
Wanted to highlight the importance of PrEP and the overall, the Getting to Zero plans that many states and cities have adopted. As the slide shows, it all starts with HIV testing, which many of our DIS staff do in-house and in the field. So for a person testing negative, and engaging them in a conversation about PrEP if they have an increased risk for HIV is a good place to start. And for folks that are testing positive, then we can connect them with medical care. So the overall goals are to, increase PrEP, increase viral suppression so that we can get to functional zero with HIV. We've seen nationally that there has been a decline of overall HIV infections because of these initiatives. And I wanted to highlight an article that came out in Chicago just in December of last year that HIV diagnoses were down 19% since 2014. And it highlights the work that we're all doing to get us to closer to zero. I'll skip this slide. It's just a bit about our overall prevention program that we've talked about. And I thank you for your time.
Thanks so much, y'all. Our final speaker today is Gerardo Orozco Pacheco. He is from the Colorado Department of Public Health and Environment. He works with the DIS there. He was formerly the subject matter expert for the PrEP program in Colorado. So take it away, Gerardo.
Thanks for the intro, Leandra. Again, this is Gerardo Orozco Pacheco. I'm currently a DIS at with the Colorado State, but I was the PrEP specialist for about 2 years of the duration of the program. Thank you, Leandra and Lacey, for inviting me, by the way. I'm pretty excited about this presentation. Give me just a sec. Okay, here we go. All right, so I wanted to quickly start with an overview of the content of the presentation, but also with the question that we picked. we get to talk about how we motivated our DIS to talk to clients about PrEP, right? We're going to be talking about HIV in Colorado briefly, the training that we did for DIS, outcomes and sustainability. If you have questions, again, reminding you that you can type them in the box, the chat box. I wanted to start with data really quick because this is a motivator. I know that data, most of us use data to drive what we do. It should be the base of why we make the decisions that we make. So I wanted to start with this motivator. In Colorado, in the duration of the project started in September of 2015, ended in September of 2019. As you see, we see kind of the same national trend, white persons followed by Hispanic, then Black or African American, same with the HIV diagnosis. 20 to 39 years of age is what we see here in Colorado for new HIV transmissions. I also wanted to quickly add an overall graph of the people that we served, also to kind of remind you that there's a need for comprehensive and more inclusive campaigns for transgender people, heterosexual people as well. All right. So in terms of, again, sorry, going back to the motivator, just talking about what was going on in terms of PrEP linkages or the clients that we served, I wanted to stop here really quick. We served 6,000 people. These were not people that were linked to PrEP. These were people that were eligible for PrEP and were at some point participating in the PrEP cascade. This is very important. We here in Colorado learned very early on that PrEP is a lot like the stages of change. People need time to think about healthier decisions. We need a lot of patience as providers. We also need to be consistent, but I just want to encourage everyone out there who's talking to clients about PrEP and they might not be wanting to access services yet. Just know that you're planting a seed, you're watering a seed, and it is all beneficial to clients. So we noticed that pattern here in Colorado, but as you see, we also served, it's similar to the HIV incidence, the same amount, kind of the same percentages. But yeah, these were the people that we served. All right. So besides the data, how else did we motivate our DIS? I'm going to be talking briefly about focus groups that we did, the DIS Intensive PrEP Training Program, and what we're doing now in terms of sustainability. Why DIS? I mean, I think the presenters before me talked about this and talked about, I mean, we're working with high risk persons. We're talking with clients that are testing positive for those rectal infections, for syphilis. So we are really at the front line of the fight against HIV and STI. So therefore the importance of us getting to know PrEP and also being able to talk about it with our participants. All right, so how did it all start? Let me just click here really quick. I think this is a very important part of the presentation. Just knowing that we wanted to do focus groups with the DIS, not only community members. We wanted to know their biases, their level of knowledge. We really wanted to know what they thought. These groups were 100% confidential, but we were also able to answer their concerns during those focus groups. They were individual. We found out that DIS were actually pretty excited about this new intervention, about a pill that was going to prevent HIV transmission. So overall, DIS were ready to adapt. In the presentation, I wanted to use these concepts just because we really, when we started the focus groups, we really wanted to know if any of these concepts was interfering with one another. So let's say maybe DIS were ready to talk about PrEP, but their level of knowledge was not allowing them to talk to clients as they wanted to. Same with their biases. Maybe they have biases that stop them from empowering clients to talk about PrEP. So the focus groups were very, very important. And they were also safe spaces. Again, they were confidential, so DIS were able to express their concerns. The concerns that they had were similar to what people, the clients that you serve. Is this pill going to make people more promiscuous? Are people at the long-term side effects? What are those? But again, we were able to answer those questions during the focus groups. So what was the DIS intensive training? We ended up choosing a total of 5 DIS, health professionals 3. The training was a 1 full month. And some of the objectives, we had about 10 objectives. I'm just going to mention a few. The first one was to enhance the skill set of level 3 DIS to be proficient in PrEP and linkage to care services. Another objective was to take away the DIS from the role 100%, and another one was to serve an approximate of 20 people per month in the duration of that month. So as you see, we really thought about elevating the DIS position. That was one of the main goals. So what was happening during that month? During that month, DIS, again, were taken away from the responsibilities, and they were submerged pretty much in the PrEP world, which was very, very exciting to them. They were also attending our work group meetings. We always, again, from early on, we understood that client-centered services are very important when it comes to PrEP. So the DIS being able to have a strong network of providers and navigators or testers, it was very important that DIS knew what people they were working with and that they knew where to send their clients, depending on their needs, of course. They were fully supported by the coordinator back then, 100%. The DIS, again, learned about a new biomedical intervention, which was exciting. They were able to tag to PrEP to high-risk populations. They also did an after-action review process in where they talked about what worked, what didn't work. We were very interested in knowing that. And then DIS were also able to motivate clients through new and existing skills. Very important, I think, that a lot of the skills that we use as a DIS, we were able to bring in when it came to PrEP. Some of those skills are reflective listening, motivational interviewing, just making sure that the clients know their actual risk, also the urgency to contact someone, to navigate through services. That was also a skill that we were able to carry over with PrEP. All right. I don't know. I mean, many of you have heard of the phrase, we were flying the plane while we were building it. That's what happens kind of here in Colorado. These are all the trainings that we currently offer to all navigators, to community members. But the good thing about this is that early on, DIS were a part of the development of these trainings. Again, we wanted to use their expertise from that 1 month that they did the training. So yeah, it's all just a whole network of, I mean, it's pretty much everyone helping each other and advising each other on what we do, what works and what doesn't work. All right, other tools that were motivating to DIS, we developed this crafts tool. As you see in the slide, it's about choices, risks, adherence, finances, testing, and side effects. This allowed the DIS to feel well-equipped, to feel ready, to feel confident when it came to talking about PrEP with clients. I don't know if you're able to see in the slide, but like the first line, it says introduction, you introduce PrEP, but then it also, in the third column, it also has possible concerns that a client might ask you this, might ask you that. So this tool really helps the DIS, again, to feel motivated and equipped. The other tools, protocols, procedures, knowing what to do, where to go, where to send people, media campaigns helps a lot with planting the seed that I mentioned before. So being able to educate clients through our social media, through our website. The financial assistance programs also were huge, just being able to help clients with assistance, co-pays, deductibles, treatment for STIs at the clinic, and also key partnerships. Again, going back to the client-centered services, making sure that you have a strong network of providers so that you know where to send your clients. All right, what were the outcomes of the training? DIS experienced professional growth, which is huge. They felt more comfortable presenting PrEP. Their collaboration was enhanced. We were able to reach out to providers that we never talked to. We also realized, though, that we needed a PrEP navigator. After we did the DIS training, we knew that we needed someone dedicated to navigate clients. We developed the tools that we just talked about. We became subject matter experts, and then again, we were able to offer client-centered services. The opportunities that we noticed or that we saw, the training was too short some of the DIS wanted to just keep going and keep doing PrEP. Again, the need for a dedicated person, position and growth. And then opportunity is huge. Client lost motivation after a short period of time. When you're interviewing a client that has tested positive for an STI, they're going through a momentum. So we learned that that's when people will think about being healthier a little bit more than when they're not going through that momentum. So that was a huge lesson learned, knowing that we needed to reach out to people right away. All right, what we're doing now, fairly quick, again, the trainings that I mentioned, DIS are welcome to attend them as many times as they want to. We're keeping our DIS updated with the new, the discovery, what's going on in terms of resources, funding, keeping our networks strong, meeting with our PrEP navigators, just keeping those communications going. Again, the urgency to refer, just talk about that. And in terms of motivation, we're just trying to keep the DIS informed, updated. We're thinking possibly if capacity allows, we might do the intensive training again, but we'll see. And all this has to do a lot with adaptation, right? With funding changing, we always have to be ready to adapt to any situation. All right, and that's it. Thank you very much for the time.
Thank you so much, Gerardo. And thanks to all of our other presenters as well. Before we jump into the Q&A from the chat box, I want to make sure everyone's aware of the DIS Slack workspace that NCSC has. So Slack is the communication platform we have for our DIS community of practice, where you can chat with DIS across the country and share resources on any topic from field safety to technology and partner services. So if you'd like to join the Slack space, you can use the link that's in the slide deck here. Tiffany will also paste it in the chat box. So you can just click on it and join the Slack space from there.
Now we'll be taking questions for the presenters from the chat box. Please feel free to submit your questions here if you haven't done so already. Our first question comes from Isaac Wade. The question is, why would PSA, and this is towards DC, need to get testing and treatment before starting PrEP? Since someone cannot yet have their STI test result but benefit from PrEP, and then they kind of had a two-part question, and why use the term suspect when it sounds very stigmatizing? And this
well, I need to apologize because I'm a little older. I'm one of the older DIS, and a lot of the terms I use may not be as socially conscious as they should be. It was not meant to be in a disrespectful way, but we always talk about partner, suspects, and associates. And what was the other part of the question?
Herman, let me speak on that as well.
Okay.
Based on what I spoke about is when we do follow-up with patients who, when we do an investigation and we find out that they are HIV negative, then we will also ask about PrEP follow-up and if they want to enroll and initiate it. That's the way, that's the process. So if I'm going out and I'm going to notify a person of their positive test and I don't know what their status is, then I need to get them tested. And then during that conversation, we can also say, well, do you know your HIV status? And if you don't know, let's get you tested and let's move forward with possibly talking about PrEP. We can, during that conversation, PrEP is also spoken about. And what I mean about partner, suspects, and associates, that's CDC guidelines when we actually follow up on patients. So if you're not familiar with some of the coding that we have with follow-up, that's one of our referral types. So one of our referral types is based on a partner, a suspect, and associate. So partners are actual sex partners. Suspects are persons who that we've talked to a partner or someone that could have been suspected of having an infection. So that doesn't mean that they're a suspect, but these are codes that we've always used. Maybe that's something that we need to address in the future with changing those, but those are referral types that we use for follow-up. These are internal codes. Those are not codes that we use outside of our follow-up.
Thanks, CC. Our next question comes from Michael. Michael asked, what labs are obtained to align with PrEP history? I believe this was geared toward DC when you all were doing your presentation, but any of you can speak to that as well.
Well, at our Health and Wellness Clinic, we use LabCorp to do all our lab results. We don't have a state lab anymore. We have a state lab, but we don't use it. We use LabCorp.
I think they were more so asking about which labs are actually drawn.
Oh, we do a 4th generation. We do hepatitis drawing. We draw for syphilis. We do, was it hepatitis? And we also do hep A.
Based on our week one lab review, there's a 4th generation test. They also look at review of the creatinine and then as well as hepatitis C. We're also looking to vaccination needs such as Hep B and surface AB and HPV. And then also do a side effect review after that first week.
Okay. The next question is from Michael. No, we did Michael already. Sorry, Brett. And Brett asked, how many attempts to contact clients do your DIS make at a minimum?
Is this for DC or for?
I believe it was for DC, yes.
And can you repeat that question?
How many attempts to contact your client does DIS make at a minimum?
At a minimum, we do it 3.
Okay.
We do it at least 3 attempts within the 7-day period. We do field stops, we do phone calls, we do internet, email addresses. We do as many contacts as we possibly can, but we do at least 3 physical attempts to contact the person.
And this is regarding whether or not the person refuses or having that conversation. So can they clarify, is it when the DIS actually have that initial interaction with the patient, or if we actually, if we interviewed the patient at the time, we will schedule an appointment, and then we will follow up to see if they actually attended that appointment. And if they don't, then we will actually follow up and ensure an attempt to actually try to re-enroll them or set another appointment for them.
Okay. Our next question is from Patrick. This is for Herman. Are you getting a good return rate using the 7-day initial PrEP supply?
Yes, we are. I think we're at about 85 to 90% people come back to the clinic within 7 days. When we're doing it 30 days, the thing about PrEP, we get a lot of follow-up on it. But we were finding out that a lot of people didn't come back. They would go on the portal, find their lab results, and they may not come back. But with the 7-day return, we know that we'll get them back in. Also, we'll be able to do vaccinations and things on them, and also be able to get them to understand that, to be able to check their adherence and making sure they have any side effects, and also be able to know that they're serious about trying to go into PrEP, and then we can give them a longer period of a longer prescription. It's worked really good for us in the last year.
Great, thank you. So another question that came up in the chat from Sarah was, do you only offer the initial 7-day prescription for people with no history of kidney issues? She was wondering how they could provide prescriptions without a CMP panel back yet. And any of you can speak to that from your jurisdiction.
This is Tony. We would have to, I'll reach out to you if you can give me your information. I can connect you to our the person who was over our PrEP program at DC Health and Wellness Center, and they'll be able to explain more in detail the process.
Did Colorado or Champaign-Urbana want to speak to that as well? Another question that came up was around the benefit of doing the 7-day follow-up. And if you have any insight about that from where you are, or any kind of follow-up that you do in that initial period.
This is Nancy from Champaign. So I might be talking about 2 different things here, but related back to the kidney function testing, we don't do a 7-day like initial prescription. We just go all out with a 30-day and 2 refill prescription. So if somebody comes in and presents to us, with some type of kidney disease or lower kidney function or something like that, we will generally tell them that they need to speak to their physician first. But if they have no indication of having any type of, lower kidney function, we go ahead and prescribe, and then if we get that creatinine level back and there's an issue, then we would contact them and explain to them that they may want to quit taking the medication and, follow up with their doctor about their kidney function.
And this is Candy. We do have contact in the first week with our PrEP clients as well. So following up to make sure that they didn't have any issues picking up their initial prescription. They don't have any questions about adherence or checking on side effects and those things too. Because I do think that call within the first week does help reinforce their them starting their treatment.
Okay.
And this is Gerardo.
Oh, go ahead. Sorry, you can go ahead.
No, just really quick. We in Colorado, we do the same. We try to follow up within 1 week, side effects, any other medical problems. But we also developed a tool for retention. So we found out that there are clients who need more hand holding than others. So we developed this tool that allows us to follow up with clients at a 1 week, 1 month, and then 3 months. So it's more of a case management program, but that's what we do here in Colorado.
And then our next question comes from Kristen. Kristen is asking Illinois, can you share the main demographics of your MSM population taking PrEP in Illinois in regards to like race, age, and insurance status?
This is pretty much off the top of my head, so bear with me, but I would say that the majority of the people currently on PrEP we have are probably white males. Age, I would guess, is between 28 and 45, and insurance status, I think, is about 50-50 with private insurance and Medicaid.
Great, thank you. Our next question is from Christy. Christy asks, with the increase in acceptance and use of PrEP in the community, have you found an increase in the rates of other STIs? She's heard that some patients feel like they do not need to use condoms any longer as they are, quote unquote, immune to HIV. What are you all seeing in your jurisdictions with this, and how are you addressing it if you're seeing it?
I'd rather have you.
So in Colorado, we...
Please go ahead.
Oh, so in Colorado, we've talked about this, but we don't, we see a connection, but the reason that we see an increase of STIs, I think, is because people are getting tested more often, so we're catching those infections early. But it's not defined that there's a connection between a rate of STIs and PrEP.
We are seeing the exact campaign.
Same here in D.C.
Then our next question is from Vivian, and I believe this was asked by someone else as well. Are the trainings available to other jurisdictions? I think this is towards Colorado and the program you guys created.
I can definitely talk to our capacity building team, and I can get back to you, Leandra and Desiree, if that's okay. I'm not completely sure if we do them outside of the state.
Okay. Thank you. There was another question around sharing the navigation tools and resources that you mentioned using the CRAFT acronym. Is that something you would also have to get back to us about?
I think that's an easier one, Leandra. I'll be super happy to share that with you guys, but I'll be probably emailing you, Leandra and Lacey.
Okay, that sounds good. Sorry. That sounds good. Great. Thank you. One moment.
Hi, so the next question is from Zerkerna. Sorry if I said your name wrong. Does your program, Colorado, serve a substantial amount of African American clients? If so, why? Sorry, I mean, no. Why was the uptake?
uptake of PrEP lower.
Yeah. And that's for
So
Colorado.
I typed my answer. I don't have the specifics on the data, like the why people were not accessing it, but we know that here in Colorado, our Hispanic population, since like 2008, has had a very high HIV transmission rate. Therefore, the higher uptake of PrEP, I believe. We're still working though with our Black community, with our Hispanic communities. But yeah, that might be the reason why, just because the population here tends to have a higher rate.
Thank you. One last question that we'll go through since we are running up on the 3 p.m. Eastern mark. Rachel asked, a lot of patients in our county choose not to do PrEP due to it being a daily regimen. The reasoning is that it's 1 pill a day, and if they're infected with HIV, they could also take 1 pill a day so their reasoning is that it's 1 pill a day if they're infected with HIV, so why take 1 pill a day now to prevent it? What are some encouraging ways to convince patients to want to take care of themselves before they are infected? Has any of you seen this happen, and what's the messaging that you use to encourage clients?
I would say from Champaign, we would highlight the self empowerment aspect of PrEP. It's something that a person can choose to be on, choose to go off, choose to take control of their own sexual health. And I think that being a part of a medical system and engaging in preventative services like we've talked about with other vaccines is really important and really encouraging for our clients.
All right, thank you, everyone. Oh, go ahead. Sorry.
Adding to that, just really quick. Adding to what the other person just shared, I think also talking to people about their risk and how that changes in time. We know that a lot of people might be going out a lot, might be going to bathhouses now, but that might change in the future. So just kind of listening to what they have to say, but also reflecting their own risk and ensuring that they know that maybe this risk is not going to be here tomorrow, therefore the importance of you protecting yourself.
Thank you, everyone, for joining us today, and thanks to our great speakers for their time. We also ask that you all complete the evaluation after the webinar has ended in order to inform our future webinars, and the recording of this webinar and the slides will be sent out to all those who registered and will also be on the NCSD website. And I hope everyone has a wonderful day.
Thank you.